recording will start right now. And this recording will be, after approval, be made available at our YouTube channel that we have with the AI Experience Centre. So you can find us on YouTube as well. So if you have questions during the presentations, don't hesitate to put them in the chat room. And then in the chat room, I will collect these questions. And then after the 3 presentations, I will moderate these questions together with the presenters. So I will keep you, as an attendant, I will keep you muted, and also I will try, it's maybe better to also leave your camera out, but the presenters, they will remain available during the presentation as well. So I think that's the right moment now to start, and I would like to give the floor to Kurt Barbé, so that he can start with his first presentation. So Kurt, please, the floor is yours.
Thank you. So if all goes well, you can see the title slide. Is that right, Hans?
Yes, correct. Yeah. Please go ahead.
Okay. Good morning, everyone. So let's go back to March 13th, where we had a positive number of tests of around almost 560 at that particular time. So we had the start of the pandemic since the 1st of March in Belgium, and we saw the number of cases doubling every 3-4 days. At that particular point in time, we had no hospitalizations yet. And so the aim was how to predict the hospitalization peak, the inflection point, and the time evolution, but in the absence of any data. So we had no data available just yet on the hospitalizations. The first model I built was on March 13. At that particular time, I did not know that the first hospitalization would start the day after, on March 14. So at that point in time, there were many models passing by. Most of them were exponential models, but they are not predicting a lot because they keep on growing. And of course, we know that the pandemic does not stay on growing forever. Also, logistic growth models were available, and these are better, of course, but you can easily prove that these models only work at the early start of the pandemic, and so they cannot predict the events which will occur in a couple of weeks. So you need something else. Okay, the first model I developed on March 13 had this particular time evolution in red, and the observations we had back then was the initial phase of the pandemic seen with the blue markers. And the model predicted that the length of the wave would hold the society in its grasp until beginning of June 9th. The peak moment was estimated on April 19th, and the inflection point, which is the peak moment of the daily new cases, was estimated for April 5th. So that was the model of March 13. Of course, if you look at the time series, you need to be a little bit careful because we need to use publicly available data, and you need to consider that we need the active cases. For the hospitalizations, that's not a problem because these are reported. Also, the number of deaths and recovered are reported, but you need to take into consideration that the number of cured, at least in the Belgian setting, are limited to the recovered patients in a hospitalization setting. So we do not keep track of the people that recover in a home environment, in home quarantine. So I made the additional assumption that after 14 days of being sick at home, you're recovered. A second assumption I make is that if you're not hospitalized, with exception of the elderly homes, but if you're really sick at home, you do not die. So you only die in a hospitalization setting or in an elderly home. And with that, I could correct the time series such that we can actually model that. I'm not going to go into further details of that particular pre-processing because it's a little bit too technical. So what I did on March 13, we had no hospitalizations just yet. So I wanted to have some idea of what the hospital sustainability would be. And so what I did is I used a proxy statistic. So I look at the Italian case, because Italy in that particular time was, of course, further into the pandemic. So what I saw was that approximately in Italy, 30% of the positive tests were hospitalized, and 7% of the positive tests were ICU patients. So assuming that this is a similar disease in Belgium, and that we would take similar measures like in Italy, these risk measures would make some sense. So what I did is I rescaled the initial model to 30% and 7%, assuming that that would give me some time evolution prediction without any data at our disposal for what the hospitalizations and the ICU patients are concerned. And that was the first wake-up call that we could potentially run into problems, because that would mean that if that model is realistic, that we would use 74% of the theoretical ICU capacity. The ICU capacity at that time in Belgium was 1,900 beds. You must realize that approximately 46% of the beds is typically used in normal circumstances. So this means that only due to the pandemic, 74% of the capacity would be used. So this means that an upscaling is mandatory. And that's also what the statistical community communicated to policymakers, but also to individual hospitals. And I did some communication to the University Hospital Brussels, where they decided to upscale their bed capacity. And by March 19, the upscale was foreseen with a factor 2.3, with additional 30 beds of oxygen delivery. At that particular time, only 9 ICU patients due to COVID were admitted. So it's of course a guess that you want to prepare yourself in the absence of realistic data. If you confront this to what we know right now, you see that initial model was not that unrealistic. Of course, it's not perfect because it was not based on any data. It was based on a very limited time series you had on March 13, but it's not that far off. So you see that the peak load was very accurately guessed based on the proxy statistic of the Italy case. And the peak was a little bit sooner than what was predicted by the initial model. Of course, once data kicked in, the model quickly recalibrated to have very accurate estimates. But how did it work? Well, if you go to its immediate basics, it's quite a simple model. It's based on a generalized linear model where you have a logarithmic link function. And you can imagine why this model would serve its purpose, because of course we are dealing with a multiplicative model. It's not an additive model. The cases are multiplied every 3 to 4 days. So it's a multiplicative model, and we know that in a multiplicative setting, we typically are dealing with what we call log normal distributions. And so what I initially did was I looked at the logarithm of the daily growth. And what you see is that this logarithm of daily growth figures start to behave like a linear function. Of course, not in the beginning, because in the beginning you don't have the exponential growth. In the beginning, you are in a transient regime. And during that phase, the number of cases are quite erratic. So I waited until March 6th, and from March 6th, you see that the daily logarithmic growth starts to exhibit a linear behavior. Of course, it's not because the data looks like this that this model has any use or should have any potential. So we need to confront that with a more epidemiological model. And a very standard epidemiological model is of course a SIR model, where SIR is the abbreviation for susceptible, the S, the infected, the I and the R is removed. And removed means that these are the number of cured and the number of deaths. So I'm not splitting up, it's a very basic epidemiological model. You can extend it with multiple compartments, but the basic model only uses these 3 compartments. The disadvantage of that model at the left-hand side is that it's a non-linear set of differential equations, which cannot be solved analytically. So you need more data to have a stable fit of its parameters. It's not impossible, but if you only have a very compact time series at your disposal, they are not it cannot be fit in a very stable way. So what I did is I wanted to linearize that, but I already knew, and that is also reported in the literature, if you linearize these differential equations from the beginning or the time origin of the pandemic, the predictions are not very accurate. So what I did was I linearized the differential equations, but at the peak moment. The problem is, of course, you don't know the peak moment, but you don't need it because you can add it as an additional parameter. And that's what you see at the right-hand side, where T0 is the parameter for the peak moment. And I estimate that additionally together with the other remaining parameters. And what you see is that that model behaves very well, at least around its peak moment, because that was its construction. What you see in the picture, and I want to highlight the dark orange curve. The dark orange curve is the actual simulated infected compartment. That's the true solution of the differential equations. And the red curve is the approximation around its peak value. And you see that these 2 models, the dark orange and the red curve, they agree, they're not coinciding, but they are agreeing up to the peak moment. After the peak moment, the linear approximation I'm using is not very accurate anymore because in reality, you have a skewed behavior. That skewed behavior is due to symmetry not observed. But this is why the model works pretty well and why it explains that a log linear growth model is working. Additionally, what I did was I made modifications in order to correct the bias that you're observing after the peak. So what you can do to give some additional model flexibility without overfitting is by using a linear slope, you could also use a higher order polynomial. But what I specifically did was piecewise polynomials, because that also fits into the time varying nature, because there are pulses, and these pulses are affecting our behavior. So you can assume that due to the changes in society, the parameters are not time invariant, so that you need to modify the model at specific points in time by knot points. And that's what I did, such that the model automatically selects a knot point, and this knot point was selected on April 6th. That's what you see in the bottom figure. That gives a better approximation because it provides a skewed behavior to the right after the peak moment. But what you see is that I still obtain a systematic error. That systematic error is due to the weekend effect. The oscillating nature of the weekend effect pushes away the observations from the estimated prediction. So in order to compensate for that, you need to model the weekend effect explicitly. And I have chosen to model this weekend effect in a non-parametric way. If you do that by introducing an additional Fourier coefficient, you get a much better behavior. You get the weekly weekend effect, and you eliminate or you correct the systematic error. At the end of the day, this is not a very complicated model because you only have 7 parameters. You have 3 slope parameters. You have 1 gamma and beta coefficient due to the SIR model. You have a knot point at this, in this model, and you have for the weekend effect 2 parameters due to the Fourier coefficient. This is the current point in time where we are. You can also use this model to do some forecasting. You can question yourself, how would the next COVID wave look like? Of course, these are simulations. These are not real predictions anymore because it's not data-driven. So you need to assume some things. You can assume an optimistic case. You can assume a pessimistic case. The rules how we are simulating are based on the modeling consortium in Belgium. So we guessed from a meta-population model from the colleagues of Hasselt what good simulation settings would be. And we all use different methodologies. And this is what comes out of the methodology I'm using. And that agrees pretty well, for instance, with the model, with a much more complicated population-based model that the colleagues from the Université de Namur are providing. So that's my short introduction to the COVID modeling based on very compact time series. That's it, Hans.
Okay, thank you, Kurt, for this introduction. I think indeed it shows what evolutions that you also applied during the past weeks, and the adaptations that of course were made based on the insights, also not only what happened within Belgium, but also with our colleagues in Europe and abroad. The next presentation will be given by Nowé, and please, you can share your presentation now.
Okay.
Yes, yeah. Perfect. Okay. And we hear you perfect.
So as Kurt already introduced, so we have these models that can fit the epidemic, but of course we have many kinds of epidemics. And now I cannot control my slides anymore, which is, yeah, okay, I'll do it this way. So we have flu, which is a well-known epidemic where the virus transitions between people. We have also epidemics that are affecting animals, for example, the mad cow disease, where the transmission mainly goes between the animals. We also have epidemics where the disease goes actually from one person to another one, but is transmitted through animals. So for example, mosquitoes. And of course, we have Zika that we all know because of the current, COVID that we all know because of the current situation. And because we have this variety of epidemics, and we also have a variety of possible models, I would say. Yeah? So what Kurt was talking about was what we call a compartment model, or a SEER model in his case, where we have people who are susceptible, so they can actually still get infected, and then they are in the other box, in the infected box, and then hopefully they recover, or in the worst case, they die. And these models allow to think about the evolution of the epidemic in a, let's say, expected way. And then we get graphs like this, and that tell us how the different compartments will evolve. So the distribution of the people, so they will either be in the susceptible box, or they will be in the infected one, which is the red curve, or they will be recovered. So your population will evolve over time over these three boxes. But we can also use it to like simulate the system, but then taking into account the stochastic effects, and then we get some to what Kurt was already talking about, a worst case, a best case scenario. And so these are these compartment models and what they tell us. But we can also have more complex compartment models like the one you see here, which is actually also interesting in the COVID situation, because as you probably know, a lot of people are asymptomatic, so it means they are infected, but they don't show any symptoms. So here in the middle, we have a more complex granularity, you could say, about how people can be infected. So they can be asymptomatic, they can show some symptoms and be in quarantine, or they can have severe symptoms and end up in hospital. So this is just to say that we have different types of compartment models. And we can also go a step further and make meta-population models. And what we then do is we have this compartment model. So here you see a simple SIR model where we actually make the difference between the group of adults and the group of children. And we can also model the contacts we have between these groups of people. So I could have added here, for example, also elderly people, so children, adults, elderly people, and then I would have this yellow arrows between these groups of people showing the kinds of contacts they have. And at the beginning of the epidemic, we were getting the guidelines that children should not visit their grandparents. And so that would affect here this kind of yellow arrow, because then children would not actually have contact with elderly people. But we can also go further. So here you see another, here we have Great Britain, and we have here compartment models for the different regions. So for Wales, England, and Scotland. The reason why we potentially want to do this is because these regions have different properties. So the SIR models we have in the different regions can have different parameters. We can even go a step further and have individual-based models. So here you see an individual-based model, but not on epidemics, but on behavior of people at festivals. This was actually a student project. So what we are seeing here is, so each dot is actually a person at the festival behaving in this area. So making choices about which scene to visit, which pop group to visit, and that's based on preferences. So on the one hand, they want to visit the group they really like. On the other hand, they want to stay with friends. And this determines their behavior. But you also see that some of them have had a green, I will now go back a bit, had a green circle around them. I'll try to find a good, yeah, so here, for example. So it also shows that these people visiting this festival can be ill and can infect other people. And this, what you see here at the right-hand side, is how this disease, what can be COVID, but could be something else as well, actually spreads over this population of people visiting the festival. And a bit like Kurt was already saying, is that in the beginning, the epidemic only slowly grows, but then at some point it really like escalates and it grows exponentially. Yeah. And this is also what you see here. So we could get a steep curve where a lot of people are getting infected. Yeah? So these individual-based models are computationally much more expensive, but they allow to model much more detail about the population. So for example, here we could say, we don't allow groups to be bigger than 20 people. That's, for example, one of the guidelines that we see today by the government. So we could simulate this in this agent-based simulation and see the effect on the spreading of the disease. So this kind of models, they're getting more and more complex. They also allow us to apply more and more complex AI techniques to actually come up with good prevention strategies. And that's what I'm going to discuss next. So what we did in previous research is to see how reinforcement learning can help us to come up with good prevention strategies. And first, before we go into that, I'll explain in a few words what is reinforcement learning. So reinforcement learning is all about learning from experience. So there is no teacher that tells you exactly what to do. You learn from experience. And here you see, for example, a game setting, and we all know that a lot of people will learn to play a game not by reading the tutorial, but just by trying it out. And this is actually also what reinforcement learning is doing. So we have an agent, here the person playing the game, taking actions in the environment, which is the game. And based on this, the game will transition to a new state and will also give some rewards points to the user. And this loop will continue, and gradually the agent here will learn to play the game better and better and be more successful in earning points. But we can do the same thing in epidemics. So we could use our meta-population model, for example, and to learn what the effect is about a certain action. Remember that these systems are stochastic systems, so that's why we really need to learn. We cannot just evaluate a strategy once. We will need to do this repeatedly to really have a good view on the effect of such a strategy. And we can also do this on our individual based models. As I said before, we could, for example, say that the groups cannot be larger than 20 people, for example, to hopefully not spread the disease too fast. Okay, now what's at the core of these multi-agent systems? Well, multi-armed bandits. So the main problem is that we don't know beforehand what the outcome of a certain prevention strategy will be. So these different arms you see here can be different prevention strategies, and we want to find out how good they are. So initially we don't know anything. And what is currently done in epidemics is that each of these prevention strategies are tried several times. So for example, we will try action red 7 times. It gives us an estimate of how good this option is. We will do the same thing for the green arm and evaluate what the average payoff is. We can do this for the blue arm, giving us another estimate of how good it is for the purple one and for the yellow one. And this is what people traditionally do. And then after having done this process, they will go for the green arm, which gives the highest payoff in this case. We assume we want to maximize this reward or payoff, as we call it. But we can do this in a more clever way. And this is actually what multi-arm bandit theory is providing us. So then we will just sample each of these arms once, as you see here. And then the question is which arm to pull next, which one is the most promising. Based on the current information, most algorithms would say, we go for the yellow one because it gives us the highest reward. So we will pull it again. And now we see that we actually overestimated the reward of the yellow arm. And then we will try another one, maybe the blue one or the purple one. They have the same payoff. And we assume here we took the blue one. So our previous trial of that blue arm was, well, quite in line with our second trial. But we can also try out the purple one, which seems to be a bit better. But now there's an important point. Remember that in the previous slide, the green arm was the best arm, but of course we don't know this. But suppose we would continue only with the purple arm, because that seems to be now the best one. We would actually forget trying the green arm again, which is maybe underestimated at this moment in time. So an important aspect here is also exploration. So we will also try again the green arm, and we will see that this 3.2 was actually much lower than what we see here. So probably the green arm is actually quite good. So the whole message I want to give here is that these kind of algorithms help us to balance what we call exploration and exploitation. So exploration is trying something new, something of which we don't know yet very well the outcome. And exploitation is playing safe, trying again something of which we think is more useful. And the algorithm will continue like this. So it will tell us which arms to sample, and you will see that through such a process, we actually detect that the green arm is the better arm, but we didn't spend time pulling too much the red one and the yellow one, which are suboptimal. So these algorithms actually help us to make this balance. And this is really interesting in evaluating strategies, exit strategies or prevention strategies in epidemics, because running such a prevention strategy is computationally very expensive. So we do this in simulation, but the simulations take quite a lot of time. So saving on this computation time is really important. And in a recent PhD by Peter Libert, who defended this a few weeks ago, we have shown that the new bandit algorithms we designed are much better than the ones that existed previously. So the blue line is the naive uniform sampling that I showed in the first slide of the NN bandit. The green one is what people normally do today. So it's an improvement, but we managed to improve this even further because the red line is much higher than this blue and green one. And I will not go into details of this algorithm, but you can see that we made a significant improvement there. This was all about, you have a certain strategy, you want to evaluate how good it is, and the effect of such a strategy is stochastic, so that's why you have to try it out several times. But we can also apply what we call full state reinforcement learning, which is more powerful because it will actually design the prevention strategies automatically. So we give it like building blocks and it will come up with a good strategy. So here I have, for example, a setting that we also evaluated in this PhD. It's about influenza in Great Britain. And we say, okay, schools can be closed, but only for 4 weeks. And we want the algorithm to find out when to close the schools and where, because Great Britain is a quite big area. So maybe it's not the best idea to close the schools all at the same time, but maybe they should coordinate somehow. So we use this reinforcement learning idea to come up with a good strategy, given the budget, as we call it, for only closing the schools for weeks. Of course, if you the schools forever, you will probably have a higher impact on the spreading of the virus, but this is not, of course, what you want. So what we did is we took this large problem, we divided in sub-regions because dealing with the problem as a whole is too difficult, let's say, for state-of-the-art reinforcement learning algorithms. And again, without going into too much detail, we subdivided this Great Britain area in different regions. You can do this in different ways. You could, for example, say these regions have, well, different governments, a bit like in Belgium. We have many governments that can decide on things. So you could do it based on this, or you could also do it based on how people travel and the commuting graph, which regions are more connected to each other. And then we focused on this little area below as a proof of concept. And basically we made like 4 agents, all controlling each of these regions. So 4 agents controlling all their own region and allowing them to come up with a good schedule for closing the schools. And then we saw that, well, if you do it just, if you let them just learn individually, selfish, so if you take the case of Belgium, we allow Flanders to make decisions and Wallonia to take decisions and Brussels to take other decisions, and without caring about each other, we get, of course, a suboptimal solution, and that's the blue outcome you see here. But if you use multi-agent learning algorithms, where there is a kind of coordination between the different regions, we can, of course, get much better results. But it also depends on this R0 value that Kurt didn't really talk about, but this actually says how well, easily the virus spreads. And this is a reasonable value. This is a quite high value. So you see that there's less to gain, for example, in coordinating when the virus spreads more easily. This is with the intuition behind this value. So here I have been talking about closing schools. So you can imagine that if you decide to close a school, that people actually will obey to this guideline. I cannot really imagine that if the government is saying the school has to close, that some schools would still be open. But we have seen that for some other, well, measurements or guidelines, people tend to not stick too well to these guidelines. And one is this social distancing, for example. So if we really want to do this in a good way, we also have to take into account how people will react to these guidelines. And this brings me back to the individual based models, where we can perfectly do this, and we can perfectly simulate that not everybody will stick to the guidelines, but to model this, we really have to understand how people behave. And this is what Tom is going to talk about.
Hello, can you hear me? Hans?
Yes, perfect.
Okay, thank you for this smooth transition, Anne. So let me go to sharing my screen. Okay. And then play. Can everyone see my screen?
Yeah, perfect.
So, as Anne pointed out already, my plan in this webinar is to talk about the human factor and about modeling the human factor in the decision process. So Kurt also mentioned this in the beginning, where he said, look, I cannot nicely fit one function to my data because I have a lot of problems. There were regulations imposed, so I have to change it to a piecewise function, otherwise I cannot fit it properly. Anne was also mentioned this at her individual level models. This human factor plays an essential role. And this is something that maybe people who like to fit data forget often, that is human decision-making who actually influences the context, not policy. And so Anne also mentioned this R0 value, and I just want to recapitulate this value, which is the average or expected number of new infected cases given one infected person under the assumption that everybody is not infected. So this is like the value that you should calculate at the very start of the disease. But clearly, like Kurt was mentioning, there is no data, so you need other ways to determine this R0, which is then based on data that you have later on about the disease. But this R0 provides you with like an estimate of how contagious the disease actually is. Maybe 1 second. Do you see my entire slide, or you see the box also? Everything fine? Okay, good. So this R0 is a combination of both human behavior and what is known about the pathogen. And this is very important because it means that this value is hiding a lot of information. Just as a reminder, this R0 is this thing that happens at the beginning of disease. If people talk about this R value, it's mostly the effective reproduction number, which simply is the same idea, but during the disease, where you already could have people that are recovered from the disease, or if you have a vaccine, people already have been vaccinated. Okay, but in that case, it's also a mingling of human behavioral and biological characteristics. And this mingling is a problem because if you want to now impose a policy, you don't know what you're doing. You say, okay, I'm trying to affect this R0 or this RT value, but you have there both how people perceive the risk of getting infected, and at the same time what you know about this disease. So clearly, I'm not the only one seeing this problem, and many people over time have been looking at this, and they have been proposing solutions. And so I took here a bit more extensive model than Anne and Kurt, which is the SEIR model, which next to having infected, recovered, and susceptible people, you also have exposed, which could, for instance, model the effect that you not get immediately ill after you're exposed other players, but I mean, it's just another alternative of this compartment model that Anne was showing before. Now, this entire behavioral aspect of context is captured by this beta that explains how you go from having susceptible meeting infected and then having this meeting resulting in potentially an exposure or an infection. This beta that drives this rate of change is actually shaped by the choices that people make. And in literature, if you look at literature, you can find different papers. And one solution is simply say, look, we can incorporate, we can translate this beta from a constant into a function and incorporate the idea of having frequency and density dependent effects, like the rate of contact is higher in a city than in a rural area, for instance, right? Or you can even imagine taking into account that people interactions are not everybody has the same amount of friends, has the same social life. So you need to take into account the differences in context, and you can actually model these inside the equations directly if you like to. Another solution is what Anne was showing in the previous presentation are these expanded compartmental models where you can look at age distributions and you separate them, or you can think about migration through different areas, or you can go to this lowest level that Anne also showed, or you do fully agent-based modeling. And I didn't make a fancy simulation. I just show here a simple scheme of the same spatial model where you have particles meeting, and these particles can actually then become infected during this game. But what I want to focus on are these epi-behavioral models where I don't care, or I do care about the context, but it's also very much important how people deal with those contexts and what is their perception of the risk and how they change their behavior in function of the perception of the risk. And why it is important, because this is what policy makers actually need. They need to know how to influence the perception of the risk in order to make sure that people will comply to certain policy regulations or not. And so this is for me the focus of this talk, and I will try to give you some information about that, but I will not give you any cool results like Kurt and Anne were doing in their seminar presentation. So to explain this in a bit more easy way, I'm going to define what I call the clash problem. For those who are from my generation, they might still remember this punk rock band called The Clash, and they had this song called Should I Stay or Should I Go, right? And the idea is very simple. Imagine that you have two types of people inside your society. You have those that are infected and those that are susceptible. And so each of them have to make a choice. They say, will I stay home or will I go out and meet my friends? And clearly there are benefits and costs because you know there's disease going around. So if you stay at home, you miss out. Your friends are partying, but you're at home, so you lose some benefits from this choice. But the good thing is you will not get infected, or at least you will not meet infected or exposed people in this kind of context. And you might still even have some collective benefit, because if you know that your fellow employees are going to their job and do the work, then you will still get some salary or some payment from this company that you're also linked to, but you stay at home because you want to avoid getting infected. When you decide to meet friends, you're happier because you don't miss out, you get to see your friends again, you enjoy life, but you have a risk of getting infected, and positively you get the full benefits of whatever you're doing together, as long as not everybody gets infected, of course, right? So essentially what people are doing is they're actually unconsciously comparing benefits and costs. And I heard different stories, and I saw different stories in the news that people are saying, but I'm only 25, why should I stay home, right? This kind of arguments where they say, I'm less prone to get infected, so why should I comply to certain rules? And this is an important thing because it's purely defined by behavioral choices, and you have to understand the behavioral choices in order to make a proper model. So in this very simplified thing that I'm showing you here, of course, nothing to do with reality, or it's too simple for reality, you have these susceptible and infected people that can decide to cooperate or defect. And so cooperating means I'm staying at home until it's safe, or I should not go out because then I can infect others. Or defecting means I will be fine, nothing can hurt me, I'm young, I won't be infected. Or defecting can also mean for a person that is infected, but I don't have big symptoms, even though I have the symptoms, so what is the risk? Let's go out and let's meet people, right? So essentially, you should not consider susceptible and infected. You should consider susceptible cooperators, susceptible defectors, infected cooperators, infected defectors. But the point is not that, like in Anne's case, they're following the same dynamic. They have two different dynamics, because I, as a susceptible, I can be initially a cooperator, but because I see everybody going out, I might go to a defector. I'm still susceptible, but I can become a defector. And the same thing for the infected. I might be an infected cooperator, but then I feel healthy and I'm already a week at home. I can go out, who cares? I will not affect anybody, okay? And this means that you have a coupling of two dynamics, which is behavioral changes that you actually see and the context dynamics you normally have in this kind of situations. For me, if I look at and think about these problems and how to integrate this clearly shows that game theory is at the core of epidemiology. And game theory is a theory where you discuss or you look at the interaction between people, and you know that your success is not depending on yourself, it depends on what other people are doing at the same time. So game theory should be directly implemented inside these models, and they should be used because they're so important to understand what regulatory measures will work and what will not work. Now, the nice thing is that epidemiological models are described at the level of populations, right? You saw the model of Kurt where he talks about entire Belgian society. You saw the models of Anne where you look at a lot of particles interacting with each other. So you're doing a description at the population level. And luckily in game theory, there's already directly this kind of modeling available. You have this thing called evolutionary dynamics, where you actually look at society as a whole, and you see how behavior changes over time in your society as a whole. And you can do this by simulations. You can say, I'm just modeling a 5 population like I was showing, where you have the interaction dynamics and you look how both the behavior changes in parallel with the disease propagation. So you combine these two dynamics. But you can also do this mathematically. You can actually, you have this thing for infinite population called replicator dynamics, which actually describes how your behavior in the population changes over time, given certain preferences of the players inside the population. Or you can even do a stochastic approximation using reduced Markov chains. There's an entire toolbox available of things that you actually can do. So that's good, but then the remaining question is what games? How should we model the problem of following regulations or going out, not going out, this kind of things? And for this clash problem, I gave a very simple description, but you can say, yeah, but the problem in interaction is you don't know whether you're infected, or you only know after 2 weeks whether you're going to be exposed. And staying home, for instance, only is something that you can, the benefit of staying at home, you can only see like in the next month, because then we are sure that the number of beds is not, that all the beds in the ICU units are not occupied. So you have this kind of idea on the left that you have this current infected population and you have your behavior of staying home or meeting friends. But the real benefit is coming from the future where you see that either you're in the green or the red area, right? And so this problem is what we call a collective risk dilemma. And this collective risk dilemma is an abstraction of many, many different kinds of problems. One of them is also climate change. It was first formulated in the context of climate change. And the idea is that your actions that you do now will have a delayed reward and have implications for the future. And the game is very simply defined. You have a number of players. They all have some money. And they have as a goal to achieve some target amount, some joint amount in the future. And so in every round, they can either give nothing, give 2, or give 4. And so they need for this to reach, in this case, 48. Okay. And so after a number of rounds, they have to achieve this. And then if they achieve this, they can keep whatever's in their pockets. So there's a dilemma here because of course, you want to give to achieve that target, but the more you give, the less you keep for yourself, so the lower your benefit, right? This is a kind of abstraction of what I call this clash problem. And we have done some work ourselves, which is currently under revision in the journal. Now, why do I show you this? Because people have been doing experiments. And you would say, people will, of course, be able to reach that target, and they will, of course, be able to keep their money. But if you look, for instance, at the yellow bars on the left in the A plot, there they show, okay, if people play that game and the risk of losing all your money when you do not reach the threshold is 90%, only 50% of the groups achieve the target. In red, we show our own repetition of that experiment, and we see, yes, for us it was around 60%. So this means that a huge amount of people do not achieve by themselves the target. Going back to the clash problem, if you know this, then a huge amount of people are not willing to comply to this kind of regulations simply out of their own interest. If the risk of the perceived risk of losing everything is only 50%, again, the yellow bar, it's way, way lower. And then on the right in B and C, you see the effects of uncertainty about what we know. So when we do not exactly know the amount we have to achieve, or we don't know when we have to achieve it, there's a direct impact on the decision-making procedure. As a consequence, this needs to be taken into account also in these epidemiological models. And we have been building models for this. So on the left, you see evolutionary dynamical models that my friends in Portugal have been working on a lot. And we had ourselves a little model on that too. On the right, we have a population-based reinforcement learning model that actually works in population of agents learning based on reinforcement learning to see how they deal with uncertainty in this kind of problem. Right? I'm not going to go in detail. If you want to know more, just reach out to me and I can explain that in more detail. So maybe just to summarize, what I want you to remember from my part of the discussion is that fitting is nice, and it determines your beta, but it doesn't explain anything about the human factor. And this is what you want, because this is what policymakers need. They need to understand the behavior of their society in order to know what the effect is of a certain policy choice or how it will be implemented. Evolutionary game theory and behavioral experiments give meaning to this beta, which I think is quite important, and it gives you insight on what you can and you cannot do. And I hope also I could convince you that many questions in this context of epidemics, where people need to make choices, are linked to questions of cooperation or defection, where you actually need to evaluate the short versus the long-term benefits or the personal versus societal benefits, just like climate change, but I'll not start talking about that at the moment. So if you have any questions, feel free to reach out, and that's my part.
Okay, thank you, Tom, for your presentation along with Anne and Kurt. Maybe there are some questions from the audience that one of you would like to ask to one of our speakers. Nothing came in, so I think this is all clear, and we're all statistical experts in the room. Maybe a question, maybe to start off from my part, is just out of curiosity, Kurt, maybe to see how that your colleagues are dealing with these challenges and these different types of approaches within the Scientific Advisory Council. Do you have there an aggregation of different types of methodologies and elements that have been discussed here during this webinar being present? Or do you, for example, see that there is a lack of diversity of methodology being used when the Advisory Council wants to come up with advice? Meaning, do you look are you still looking at different interpretations and different models that are used maybe in other areas as well?
Well, in the modeling consortium, where I'm a member from, there it's all SIG based, but the level of depth is different. So we have macroscopic models and we have microscopic models. And so some people take age into account, some people take regions into account, some people take specific sectors into account. And that level of detail is important, of course, because the more detail you have, the more that you can actually evaluate prevention strategies. But of course, there is a trade-off because you need data for that. And you only have publicly available data at the macroscopic level. So you need you need that chain of models because they need to be consistent in some way. If you have the macroscopic model, that's fully data driven, as what I'm doing, and that typically leads to very accurate, stable predictions. And that's the current state of society. But of course, if you want to have some evaluation of a specific prevention strategy, or you want to make a specific choice, you need to model in more detail. So you need of course some start. And at that way, you can, of course, you need to feed the missing link, which is not available in data. You need to get that from something different. And there, the macroscopic model can be some kind of reference. So this is how it typically works. And then we can, of course, confront all these models to see what is consistent if some specific pessimistic scenario runs out, you can of course confront it with other models to see where they start to deviate, why they deviate, and stuff like that, because you have a leverage effect. So if you are getting new data which comes in, some models can of course focus on that specific data point, where other models are more robust to a specific outlier, and in that way you get an ensemble of models which makes predictions more stable.
Yeah, all right. Okay, thank you for that. Maybe another question for Anne and also maybe for Tom is, of course, if you look at on more individual level and taking into account human behavior and do I go out or not, and who I'm going to contact, then of course people of course will relate that to the whole discussion about tracing human contacts over apps or by manual tracing. Maybe for is there then from your point of view and from the reinforcement modeling point of view, maybe do you have then a preference in how that then this data would have been collected by an app versus the manual tracing?
Yeah. To my opinion, they're quite complementary, and we already had a webinar on privacy issues and so on. So we see with manual contact tracing that people are like afraid to declare their contacts and this kind of things. There's limited, let's say, people available to actually trace these people. So it's I would say a normal trend that we try to rely on technology to support this. And we can do this, well, I'm not an expert in this apps and security, but I do understand what they are heading to, and I can understand they can do this in a quite well privacy preserving way. But what I do miss in this debate is what will be the policy based on the data we'll get. Normally in medicine, you collect data and you collect it because you know it's going to have an effect on your policy, on your decisions you're going to make. And this part of the debate I'm missing a bit. They're talking mainly about how many people should actually install the app for it to be successful. So estimates are like 60%. But I would like to actually look at the other side. So what if we can convince people to all install this app and collect this data? What will be the effect? And if you do some very basic calculations, which we definitely would need to fine-tune much better. But if I take my own case, I go to the VUB taking public transport. I take the train and typically also the metro or the tram. I go home. Suppose I get infected and it takes, well, 10 days for me to get this alert of possibly being affected. Well, if you do some basic calculations, I easily had contacts with 100,000, even 1 million people, especially because I take public transport. There is studies that show that because you take public transport, the spreading is even much worse because there's a limited capacity in this trams, for example, or metro. I don't know how to call this in English, the stellen. So it actually spreads a lot. So you will need to take also context information into account. So for example, we would need to know, was this contact that my app made, was it because I was on the metro, for example, were people using this protective mouth mask, this kind of things. So there's a complete discussion that, to my opinion, is missing. So suppose we can all do this, what will it learn us and what will be our policy? You cannot imagine that you will go 2 days to work and then you get this alert, you're back home again for 14 weeks, you work again 2 days or 3 days, you're back at home again, and before we know, everybody is again in quarantine. I mean, so this discussion is to my opinion, completely missing, while we can actually perfectly investigate this if you would want to.
Mm-hmm. Yeah. Maybe a final word from Tom on that matter?
you repeat the question?
Well, indeed, regarding the benefits or the pros and cons of the manual tracing versus the mobile app tracing, as unexplained, especially of course related to policy making. What do you think that that benefits are versus one choice versus the other one?
Personally, again, it comes down to human decision making. Yeah? I mean, if you saw on the news, Frank Hughes reporting on the fact that it's still not working properly. It's getting better and better, but people are not sharing their contacts. In my opinion, the advantage of a contact app would be that you don't have to start asking them this. I think there are perfect ways of securing whatever privacy you want, because I don't care who you meet, I care what you met, right? In this instance. So you could simply fill in your contacts on your phone. This data does not have to be shared with anybody. And as soon as I know that somebody on my list of contacts was infected, then I'm informed, right? This is something that I locally know. It's important to, and in the end, okay, I will know that it's my wife who infected me, or my neighbor that infected me, but why is it such a big deal that I know that my wife or my neighbor infected me, right? I'm probably going to be killed by some of our law colleagues at the VUB and the ULB, but I think it's feasible to do that. But it's like Anne also says, okay, that's fine, and then what? Right? It's not like a pill you're taking in your cure. No, then you have your data, and then what? Right? And I think in that I agree with Anne. Then policy has to be designed in such a way that people are not going to remove the app from their phone, right? And this will be not easy. So I don't think there's a magic bullet. And I think my personal opinion about this entire lockdown story is that people are nagging too much. I mean, we have to get through this one way or the other. Deal with it. I mean, and if an app can help us, then make the app so that it can help us. But also for policymakers, this is something new for them, that they're driving blind in the manner of speaking. So don't expect that they know all the answers from the start. I mean, this is like Amber saying, this is exploration. This is exploration. And we're very much in an exploration phase when it comes to COVID-19. I mean, so we have to be patient. We have to see whether we explored all options. And I think that's maybe important for policymakers. Did we explore all possible options? And then did we sample correctly to find the right option? And then we're coming back to this this theory of the multi-armed bandits, where are we collectively exploring these kind of things? And how could we best explore these options? And on top of that, inform people about your explorations. Don't show that you know everything. I mean, you don't know everything, it's clear. Show that you're exploring and explain why you are exploring. And I think that's very important.
Maybe on that last remark, indeed, Tom, to wrap this the webinar up, I think that's indeed a constant that I also heard in the previous webinars, that of course this is a situation that there is no scenario known upfront, so that it indeed from all aspects and all sectors that people involved in fighting this crisis, that a lot of exploration and finding out was there, and that we as scientists, of course, can only do our best to move fast and give these advice and these insights. But at the end of the day, it comes out in the hands of politicians to make then the right decisions, taking into account also other aspects, of course. So I would like to...
Don't be afraid to admit mistakes. I mean, everybody makes mistakes, so just be clear about it. That's the most important message, I think.
Yeah. Okay, so thank you very much also to the attendants to stick with us. I saw that everybody stuck with us with during the whole webinar, which is very good, as well as an average. So I would like to thank again Kurt Barbé, Nowé, and Tom Lenaerts for their very concise and precise presentation. And I would like to thank all the attendants, and stay safe, and hopefully we will see each other in another occasion, or event that we would organize at VUB. Okay, everybody, stay safe and take care.